Kaboom! Welcome everyone to Life and In Between podcast. Grab your latte, grab your coffee, grab your kombucha, whatever you are drinking, wherever you are from. Everybody, let's just take a deep breath. Fill those lungs, health is wealth, because today we are talking about health. We are talking about the wealth of being a fine-tuned instrument of biology. We have an awesome guest today, Dr. Eugene Manley. And to kick things off, please help me welcome Diana Gonzalez.
Thank you so much. Thank you, everyone, for joining us today. And thank you, Dr. Eugene Manley, for being here today. I am going to, let me let you know that this is such a world accomplished person that has done so much. And I'm just going to dabble a little bit and highlight a few things on what he has done. So we know he is a cancer scientist. He's a nonprofit founder. I mean, like right now, that alone, those two things, wow. And yes, health equity leader. You're an advocate, and you started a nonprofit, SCHEQ, which I'm going to have you explain a little bit about it more. You help patients, caregivers. I mean, you do everything. So I'm not going to steal your thunder. Expand a little bit more on what I haven't covered, Dr. Eugene Manley.
Hello, thank you so much for having me on. It's a pleasure to be here and talk with the both of you. I'll give you the high level primer. As they mentioned, I'm Dr. Eugene Manley, so I'm trained as a mechanical engineer, biomedical engineer, and a cell and molecular biologist. So I've done a lot of work in combination drug therapies, tumor microenvironment, and biomechanics. And then I transitioned over to the nonprofit space and started working in fundraising and development and then lung cancer. But my PhD was in lung cancer. And then along the way, patients started reaching out to ask me to help develop content and programming around disparities. And so that sort of started a little cascade about what I was going to do. And then I ended up launching SCHEQ, which is what the short version, but that stands for STEMM and Cancer Health Equity, broadly to work to increase STEM workforce diversity and to improve outcomes for underserved populations navigating the cancer care continuum.
Wow. That's a lot. That's the whole alphabet right there.
That's a lot. And I'm just taking it all in. Well, let me ask you this first question, because this is what's been, I've been looking forward to this interview. And I just want to ask you, my very first question is, what pulled you into like deciding I want to go into cancer science? Like, why?
I don't know if I had something that pulled me in, but it may have been some inklings. When I grew up, my father was a chronic smoker, and I had really, really bad asthma and allergies. I mean, I had anaphylactic allergies, and I was in the hospital probably 20 to 30 times a year just for my asthma between when I was 5 and 10. So I was always in the hospital, used to needles, used to doctors and nurses. And I said, okay, I kind of want to understand how the body works and functions. And then my family dealt with so many issues, comorbidities and stuff. And then I just saw how healthcare wasn't delivered to them. And I don't know what made me go into cancer. I will say one of my earliest science fair, oh Lord, going back. One of my earliest science fair projects was probably in middle school, where we could look at the amount of tar and nicotine in cigarettes. And so what I could do, I don't know how I found this, but I ordered some kind of kit with the bulb and apparatus, and then you get individual cigarettes, and it had a filter pad, and then you would smoke it with the bulb and then try to look at the amount of particulate matter. I was a scientist before I even knew I was a scientist. But I got a lot of stuff from the American Lung Association about lung cancer, and it had all these gory graphic pictures, which in hindsight, they could have probably done a better job, because we did a great job of anti-smoking campaigns in the 80s and 90s, but they used so much gory and graphic images that it made people think that if you get lung cancer, you only are a person with a history of smoking. And while that's the leading cause, that's not true, but this causes a lot of stigma. But as I went through, but my very first research job was in high school, at a Michigan Cancer Foundation. My science department had got me an internship program at the Michigan Cancer Foundation at the time. And then I sort of knew I wanted to be a biomedical scientist. Now, I didn't know when I went through undergrad what I was going to end up being. It just, my PhD lab happened to be in a lab that studied lung cancer. So it was just on a whim I ended up in lung cancer. But when I started my degree, we only had chemotherapy and radiation as options, and that was early 2000s. And now we have so many biomarkers and immunotherapies that they just were not there when I started. So if I'd started disparities work back then, I don't even think I would have been able to conceptualize what to do. But I think a little more time allowed me to see where the barriers are and how to educate people and how to teach them how to advocate about trials and how to advocate to get the testing they need. And I'm pretty sure I just went on a longer tangent than you needed.
There's so much good information here. Uh, I just had a random question. I've always wondered. So with the carcinogens and stuff that, tobacco and cigarettes, is barbecue considered a carcinogen?
Let's put this a different way. We know the leading cause of lung cancer is history of smoking, but other risk factors do include indoor cooking modules. So you're like, if you're in the kitchen and you have all that oil becoming aerosolized going in the nasal passageways, we know air pollution, we know exhaust from like freeways, job exposures, like if are a firefighter, forest fires. We know the other major cause is radon, but that's a colorless and odorless gas. But that's the outside of history of smoking, that's the next leading cause of lung cancer. And so and unfortunately, while these are other risk factors, the current screening guidelines are only dictated on history of smoking. So you have to have a 20-pack year history of smoking and be, I believe, between 40 and 60 or 50 and 70, and are either currently still smoking or have quit within the last 15 years. Then you're eligible for lung cancer screening, because the lung cancer screening trials showed that if you are a high risk patient for lung cancer, then screening can lead to earlier detection. The only downside is it does not do anything for those patients that don't fit in the history of smoking category. And so, unless your organization specifically includes in your screening program these other risk factors, they don't get accounted for.
What? And this radon, where is that? Is that like household paint, plastic from
Oh,
the car?
radon is everywhere. It comes up from the ground. It's radioactive byproduct, but it's colorless and odorless. I don't know if you were old enough. In the 80s, there was a campaign about testing your homes for radon. I don't hear as much about those campaigns anymore, but it's the biggest issue with radon. It's colorless, odorless. You don't know it's there, and if you don't have radon mitigation in place, you're putting people at risk. And I know there's some groups in Pennsylvania that really focus on trying to get radon mitigators in places and trying to make sure places are tested, because it's a major cause. But it's everywhere, and in places like Kentucky, which has limestone, which also has a lot of radon, the process of distilling whiskey also enhances the release of radon. So that's another factor at play.
That is nowhere safe. That's it. We're moving to the moon. Move to the moon, people. 2028.
Well, then there's radiation in the moon. So
I'm depressed. Diana, take it.
Just get a bubble. Listen.
Yeah, take the bubble.
Oh my gosh. So this is such great information that you're providing, because I just learned, I think 10 different things that you just like taught me 10 different things, and thank you so much. I learned something new. But I want to kind of circle a little bit something that's so important, and I think that people do not advocate or don't know how to advocate. And I know that something happened to you. You shared with me that something happened like with your mom that kind of, can you share that story?
Yes. So throughout my life, my family grew up poor and underserved. And so I just saw how my family got treated in healthcare interactions. And And, before my mom died, she had diabetes and had gangrene and they were doing amputations. But even before this, she would go to doctor's appointments and they routinely would ignore her, dismiss her, not listen to her, or they would give post-visit notes, but they'd be in my chart. But if you can't take the time to tell the patient what to do, you can't expect them to do it. And I don't mean that in a deficit frame of mind. I mean, you have to be able to make sure they understand what to do. Don't just say, oh, here's a printout. No one's going to get through 5 pages of jargon and then read the instructions. I would, but most people are not, and they don't understand my chart jargon. But she went through a lot of that, and then even in hospitalizations, there would be notes on the door that she wanted her lights left on at night, but they would cut them off. Say they just were snippy and rude. And so, and I saw this with her. I saw it with my grandmother, and then unexpectedly, I had fractured my foot December 2026, Jesus Christ, December 2024. And then I ended up having reconstructive surgery on my foot in March. Now, mind you, I have a biomechanics background. My PhD was in biomechanics. I did a lot of years of jujitsu. So I knew what the surgery was going to be like in the pain. And the surgeon and I had a comprehensive post-surgery plan in place. And I asked could I get put in skilled nursing for the first few weeks because I don't have any family out here. I remember how hard and impossible it was just when I was in the splint the first week before I got in the boot. And he agreed, and that's what we wanted. But unfortunately, the hospital staff at Mount Sinai Queens decided to um, lie in my medical records and say I had no pain, said I could ambulate. And then they were trying to give me early discharge notices, trying to ask about my ability to pay. So all these things are not medical guideline at all. And because the surgeon did not have direct admitting privileges, he couldn't even get in the records to see what they were writing. So basically, they iced him out of the records and they kept misrepresenting stuff. And we know if we look at the history of medical care, so many Black patients, it's reported that they don't feel pain. But in my case, I have no idea how you can say I have triple bone fusion and I have no pain less than 36 hours after surgery. That is physically impossible in any shape, form, or fashion. And so I only learned about this about 3.5 weeks later when I was at home trying to finally read the medical records. But most people don't read the records. I happen to read every instance of where there was a fabrication. And so it made me realize that people really need to understand when you go in hospitals, have a medical proxy that can go with you in person. I had a proxy, but they were in Florida. Understand that hospitals will use something called AO3, which is alert and oriented times three, which means if you know the date, time, or space, or where you are, no matter how lucid you are, if you can at least notify three things, then you're considered alert. So they considered me alert when I was clear. I was not in my frame of mind because my brain is always rapid fire, and I knew I was going to be out of it. But they kept saying, "Well, he agreed," and I said, "I didn't agree to any of this." So I made a whole series of posts about navigating medical care, how to make sure you have a proxy, who to contact at the hospitals when you have these misrepresentations, and you have to write certified letters to hospital leadership because they have to then see it and sign and acknowledge it. And then you watch them write dismissive letters back to gaslight you. Well, we did everything according to board. I said, yeah, absolutely, you did not. But then you learn that there's also the hospital Joint Commission for Hospital Accreditation, which certifies hospitals. So if you have an issue, you can file with them. New York State also has something, the Department of Education here. They don't certify doctors, but they certify physical therapists and those kind of professionals. And so because the physical therapist was the one that blatantly misrepresented my chart, I filed a complaint for the Department of Education because they did not do their professional guidelines. And it's documented. So you have to know how to file these things, report, and then I reported to my state representative. And then, of course, you always have the ability to blog and write and speak about it. But so many people don't understand how to do these things or navigate these things. And And when you're in so much pain, the last thing you're thinking about is trying to fight a system because you expect them to treat you with respect, but clearly they decided that, oh, because I'm poor, assumed to be poor, black, and on Medicaid, that of course I know nothing. And so that was the assumption they made. And probably what happens is they're so used to just pushing people out who
Mm.
don't know how to read records and know how to advocate. And I just happen to be stubborn and steadfast in my convictions. But I just worry about all the other poor, black, underserved patients that have been at that hospital that have been unnecessarily released early and have misrepresentations in their chart. Then they end up getting injured again or having readmissions and they don't even know half of the reason why.
That is sad. Yeah.
Wow. So
That's, yeah.
that's and I think I can speak for myself where I've also had experiences in the past where doctors have not heard. And I think there's a stigma out there that a person of color can tolerate pain more for
Yeah,
whatever.
that's in the books for some reason. For some, but the old experiments were done on black women with no um anesthetic. I think they're and you know what I'm trying. The word I'm trying to say is yes,
Anesthesia.
yes. But a lot of that was done in the past, even before we had anesthetics, and then and these were done by people that had eugenics philosophies and stuff. And so, oh, but they don't fit. No, you just treated us like we were subhuman.
Yeah, and still we have doctors and physicians and that are still continuously doing that. And so tell me a little bit. I know that you covered a lot of the steps that how people can proactively take charge and all that. And but what do we do with those people that are just afraid or right now we're facing people that are fearful because I'll bring to highlight people that are undocumented or people.
Yes. Oh my God. Yes, that is always you. So undocumented, whether English is your first language or not, because not, and it's not just Spanish. It's in subpopulations, their parent or grandparents don't speak English, but they still need care. And then you get in these issues sometimes, for good or bad, where you have the family member trying to translate and they may not say all that needs to be said, but then you also don't know how it's getting conveyed. And so there's these breakdowns. And so we don't have enough providers to reflect these communities, but we also in general don't have providers from these communities at all that have that lived experience and or have empathy, because a lot of times it's empathy and lack of, with a better term, missing leadership. When organizations are more obsessed with length of stay or how fast we turn people around or how much money we make or don't lose, and then you lose the whole concept of treating patients, then that's a leadership failure.
Absolutely. Another target, I guess, people that we can actually talk about a little bit more. What about, I know there's a within the community, there's a mistrust. And it's difficult because there's that lack of trust. How are you able to, I mean, convey to these people that are listening? I just don't trust doctors. I don't trust the hospitals. Oh, and I'm sure you've encountered many.
Yeah. Well, these concerns are not unfounded. Some people act like, oh, why don't they listen to the doctor? I mean, this doctor's great. I said, when you are from a group that have routinely been dismissed, disregarded, and treated like you are less than human or not important in any of your other healthcare interactions, you already don't have trust. Let's say you go to a major cancer center, but you're from an underserved community, but this cancer center is all nice and spiffy and clean. And it's a certain demographic in there, but you go in there and you're like, I see nobody that looks like me. I see nobody that speaks my language. I don't feel like I belong. So you're already trying to battle that. So you can't really get rid of distrust because there will be no distrust if people felt safe. but people don't feel safe because they're never heard or listened to. And then usually we only hear, keyword hear, about this stuff when something major happens, like the woman that was, got kicked out of the hospital and had to birth on the side of the road. But these things happen way more frequently than normal, and they should not be. So when your humanity leaves the window, the patients don't feel, why would they go? Because they're not going to listen. And often, you're fighting to get that first opinion or that second opinion, and it's really, really hard. But I just try to make sure patients know you are within your right to ask questions. You're within your right to ask for second opinions. You're within your right to ask how something works. You're within your right to ask what's going to be done, how it's going to be done, when it's going to be done, when are we going to get the results. And then you are also within your right to ask what these results mean.
And that sounds like the thing. It's actually speaking up instead of just, being passive.
Yep.
There's times to speak up, and I want to kind of throw throw a big question out there. How did we get here? I mean, healthcare, it's supposed to take care of your people, and then I guess lobbying and everything, it's all about money instead of people. Uh, we just took my little one to the ER. It turned out to be just like a cold or something, but $5,000. Nickel and dime, everything. It's like,
Yep.
how do people rebound from this if they don't speak the language, if super low income? It's a trap. It's a healthcare nightmare.
One of the biggest issues that we have is that medical bills, unsuspecting medical bills, um, medical, you're getting charged and you don't know what it is. Some states have laws where you have to clearly state
Mm-hmm.
what you're being billed for, but often when you do ER visits, you don't know. The other thing that will get you for money are ambulance rides.
Mm-hmm.
I know plenty of people that have been injured but were refused to get in the ambulance because you don't want to see a $1 to $4 or $5,000 charge for a 15-minute ride. You may need to be like, nope, I will go another way. I will crawl. I will get a taxi. It's just because you're afraid of the bills, and then you don't even know what you're supposed to fight and dispute because everything is just compiled together.
Uh-huh.
So, did I answer your question? I think.
So I guess, like, so when I hear, like, my mom worked in a hospital in Seton, so it was owned by nuns for a long, long time, and then the consolidations and the buyouts, and
Oh my God!
it
Yes,
became a
yes.
profit machine. And the fact that I've applied for grants, for some of the work that I do, but it's funded by millions of dollars from hospitals, and I'm just like, why do hospitals have all this excess money? I mean, it's a machine, it's a money
Yep.
machine here.
And part of this is, we have venture capital that is coming in, and they are buying up different hospitals, local hospitals, more rural places. And then whatever a hospital is purchased by venture, it usually goes down here because then they try to cut costs. They try to get rid of the doctors that are doing a lot of work. And I'm sorry that someone has started knocking on the floor upstairs. That was not intended.
They have a medical
but
bill and they're mad. Ugh.
so I know, but but because of that, they force a lot of practices to consolidate or close, or they go in, get rid of all the services, get rid of all the extra stuff that people need, and then the service just completely tails off. And then once there's no more money left to be made, then they sell it, but then the hospital's a shell of what it's supposed to be.
That is crazy. And
And then the
we
patients
saw,
lose and the doctors lose, and we're getting a lot of doctors that are just leaving because they just are frustrated with it.
and this is where things escalate. And, that Mariano guy who shot the United Healthcare CEO over stuff like this. I mean, it escalates, and it's just this perpetual. They what they did here at the hospitals in Austin, they used to have translators because we have a really big Mexican
Yeah,
population here. They got rid of most of the translators, and instead what they would do, they would call these computers on wheels, a cow. They would wheel in a little computer screen, and a translator from some other area would come in, and you're talking to a machine now virtually. He's like, oh, hey, by
Yep.
the way, you have cancer and you have this. And it's like,
And you
he
know, when
read it.
the AI can't replace human interaction, human thought, human feeling. So it makes care harder to deliver. But they also got rid of a lot of stuff in Texas, focusing on Hispanic and Black and other underserved communities. So it is quite a challenging time to be in healthcare, whether on the patient side or the provider side.
And then with the ACA cuts, the open market getting gutted. That
Yep. Yep.
I just got off a Zoom call with our provider on the open market, and I'm just like, everything just skyrocketed. It's like you got to get another job just to pay for
Yep.
the
The premiums
insurance.
went up, and people always say, "Well, why didn't you go to the doctor sooner?" It's not so much that people didn't want to go to the doctor sooner; they're worried about what it's going to cost. And sometimes, how do you get time off work when you're at often not a not an executive role, but you're in more of a public facing role, and you don't have the luxury of taking days off or getting hours of work, and you're at call or will call, and they can just fire you. So you don't have the luxury of just running in. And then if you're doing caring for multiple people, like you can't just drop your stuff and go. And so there's a lot of factors at play that people don't understand. And then they'll say, well, this patient didn't show up, so they were non-compliant. I'm like, did you bother asking what they were going through, or how many jobs are they traveling, and how much transportation they have, or was there even transport to get them there? These are things that really factor into care access and care delivery and just being able to engage.
It's so broken. Yeah, I'm getting
Yes.
radicalized, Deanna.
Hulk smash.
Yes, they are. You mentioned something that just kind of opened my curiosity. You talked about AI.
Yes.
And you talked about, well, I know that there's a link between the AI and cancer care. How is AI already influencing cancer? How
Well, if we talk more broadly, AI is already in healthcare. That's already there.
right.
If you look at, sometimes doctors use AI to, if they get done with patients, which is actually good use, they can then speak to Mike and then it'll go speak to text. So then they can get their notes down faster to help them process. But it also shows up when, you know, charting. And sometimes you think the negative side is when insurance uses it to decide who they're going to decline without even talking to a person. So, but in cancer, there are good pros and cons. On the one hand, it can help in some cases identify lung cancer earlier than would be normally detected. But in other instances, it can exacerbate disparities because typically, depending on who has developed the AI in the system and the populations that are included in the design of that algorithm, it will tell you who it actually is going to work on. So you can't sit and say, we're going to have this AI that can look at dense breast and then say, we've got the solution, but your population is all affluent women that are not from the inner city. And we know that Black women tend to have dense breasts, which means they have increased risk of breast cancer. And so when you don't account for these populations, when you design the stuff, then you have either a solution that doesn't work or it's a solution that's for a majority population. But then if you look at the subset data, it is not accurate. So I tell people when you're trying to think about AI from the design side, you have to think about who is included, who's on that design team, who's in leadership. Because if you don't have people from these communities at all stages, I guarantee the underserved and marginalized are never going to be accounted for.
There's a
And
certain demographic mind when they build this stuff. So, yeah.
Yep. And then I run on, we got this great solution. It'll solve X. And you're like, what was your training set or test set? And who did you include anyone else? And then you're like, no, but we got to like, no, you don't have a solution. You don't you have an you got something. It's just not a solution that's going to be widely applicable.
Yeah.
So and I know it's a lot of AIs, these private companies that are doing this, and so a lot of people are. So who polices them? No one, right?
There really is no explicit policing. We're working on getting AI guidelines in, but we don't have core fixed and set standards. So that's why it's really up to those developing the stuff to do their due diligence.
Mhm.
And unfortunately, we know over time, waiting on people to do their due diligence on their own never really works.
Hmm.
We would love people to be egalitarian, but we just know, sadly, that just does not happen.
So this is where we should encourage our youth to start going into like the STEM and going into AI, our um focusing on our, the underrepresented communities to really focus in on that. And you are the face for like the future generations where, what can you say? What can you encourage? What encouragement and could you give them?
Well, I just want them to know that there are many, many careers out there. You don't have to do a career in AI. You don't have to do a career in medicine, but there's so many career paths available now. I will say AI has made it a little bit easier to do stuff virtually and videos and TikToks and stuff. But I would say just find something that you're interested in, learn how to do it well, and then, and if that moves you, either make it your own business or work under companies you get the skills. And maybe if you want to make your own company, go do it. It is much easier to launch your own thing now than it has ever been. It doesn't mean it will be successful. I don't mean that flippantly, but but it is at least easier to develop stuff. But go get those skills you need. I know, like girls who code, that helps women, do coding. We have National Society of Black Engineers, had a National Society of Hispanic Engineers. We have like SOCNUS, which is Society for the Advancement of Chicanos and Native Americans in Science, or STEM. And they have their big meeting every year. And that's such a great meeting because they've been around 52 years now, I believe. And so they just do a lot of work with for undergrad, grad to postdoc. They cover the whole career spectrum, and they're just doing a great job.
Wonderful. Correct me
And
if I'm
that's
wrong.
what we need. Yeah,
Oh,
more people to infiltrate and be that representation instead of just adding to it. It's like change the entire system to
Yep.
reflect everyone.
And sometimes systems are not designed to be disrupted inherently. So sometimes you have to go do your own thing and be the change that you want. Because waiting for others, unfortunately, won't always pan out that way. And then you'll still be chasing and chasing. And then if you won't listen, then I'll just make my own thing.
you're not invited to the seat at the table. Start your own,
Exactly. So many people spend their time chasing to get in a room, then they get in a room and then they have to moderate what they say, how they speak, or how aggressive are you, or are you compliant, or are you too loud, are you too timid? And you're like, this has nothing to do with the task at hand. So sometimes you have to make your own room and then fill that room with people that mesh and understand what you're trying to do. That's a harder path, but that's typically the way you will make some kind of lasting change.
Boom. And I'm proud to say we've had people like that on the podcast. People that just went out and you don't look. Nobody here looks like me. I'm starting my own. I mean, CEOs,
Yep.
everything. So bring it. You hear that, listeners? Start your thing and don't wait for that seat at the table.
Yep. Be content in who you are, and don't let anyone try to pigeonhole you in a box. Now, unfortunately, the system says you must do A, B, C, D, and E, but get what you need, learn what you have to. But if it's not a space where you can grow and flourish, you don't have to stay.
Exactly. I
Boom.
love that. And that's the message that we need to send to our youth and even people today. Like we're now pivoting. We're seeing right now in the workforce that people are now pivoting. We were just talking about AI that And a lot of jobs are being cut. A lot of companies are restructuring a lot of things, and people are now pivoting. A lot of nonprofits have lost their grants. A lot of
Yes, yes, yes. Yep, a lot, especially in the health equity, DEI. You can't say the word black, you can't say the word woman, you can't say LGBT. And so the problem is you can try to silence people from using the words, but the work still needs to be done for these communities. They still have underrepresentation, they still don't have a voice. So who's going to step up and still advocate for them?
exactly right. Yes, that's exactly right. So, I wanted to know, are you currently, and correct me if I'm wrong, I might have misread that, but do you mentor? Um,
Yes. So I mentor on and off. So I've been in several mentorship programs. Well, let me rephrase this. I've been in mentorship programs coming through, and now I mentor in different capacities. So right now I often oversee a lot of public health, doctor of public health and master public health educational projects where I try to give them a project either related to infographics to increase health literacy, let them look at some kind of structural issue and look at what leadership decisions were and weren't made, or something that impacts medical care and medical delivery, so they get to understand why the work is important for these underserved communities. So I try to develop projects that way. And I have run and developed mentorship and training programs in the past, and it's still something I do. I just haven't done it much the last 2 years because I've been trying to ramp up the nonprofit in our lung cancer summit. But that is what I do. And I am working on filing my paperwork for my separate solo consulting firm that will be also helping orgs develop, leadership, mentorship, and training programs. So,
you mentioned the summit. I'm gonna home in on that. Tell me about your summit. I want to hear more.
the summit, we started this program roughly a little over 3 years ago, and the whole idea behind the summit was it was just sparked by an idea. I said, well, how do we have anything for Black and Hispanic people navigating lung cancer? And we look across the region, and there's really nothing for them. So that was sort of the idea behind the first summit, was just what can we do to talk about disparities and inequities? And then I broadened the summit to still focus on Black and Hispanic, but other underserved communities. But the whole idea behind the summit is we want to bring together patients, researchers, clinicians, hospital systems, payers, etc., to not just talk about the problems that these underserved communities face, but what solutions are different people creating at all levels that are actually reducing the disparities, reducing the inequities, and or improving outcomes. And so what we have is patients, caregivers, and survivors who often, when they're Black or Hispanic, they don't get the same information that majority groups do. They don't feel seen, they don't get heard, they don't get the biomarker testing. So if we can put them in a space where they can learn more about the disease, learn more how to advocate, and then meet people either locally or nationally that can help them, or maybe one of their friends or family members, then we put them in a position to get more, to get better care. So that's what we do this summer. So we use that to also build our patient population, but to give them that sense of empowerment. And then by bringing in all these different stakeholders, they talk about the programs and interventions that they've done that actually remove an inequity or a disparity. And by bringing them all in the same space, you break down these silos that typically exist between just a patient event, just a research event, just a clinician. And then you get that real synergy because then people, oh, I can actually talk to them. And that's what we're trying to do. But we really focus on solutions, not just problems, but it's solutions, because health equity, by my definition, is intentionality. It is, what are you doing to remove a disparity or inequity? And that does not mean just Black or Hispanic or underserved. It could be rural, it could be urban, it could be, Asian females with lung cancer. But whatever it is, you have to intentionally design an intervention to remove or mitigate a disparity that impacts some group relative to the majority. So it's whatever you're trying to, you have to be intentional about that intervention.
Wow. That sounds such a great thing that you're doing. And how long has this been going on? Like
A
3 years?
little over 2.5, well, almost 2.5 years now, because
Okay.
I launched it in August of 2023.
Okay. That's fantastic. Well, congratulations on that. I'm sure it's
Thank you.
growing and everything. And that's so wonderful, the great things that you're doing. I mean, I have to say that coming in and coming in, I wasn't prepared to learn all these things, but I am so happy that I'm coming out more educated. Like so that's a great
And
thing.
thank you. And my job is always to make sure people leave with some piece of information or resource or something they can do to either help them or someone else they know advocate for either care they should get, to how to navigate a STEM career, or to understand the pros and cons of leadership and how it applies in healthcare.
That's important. Now, I know that if someone, any of our listeners that want to contact you or even be part of your summit or learn a little bit more about you, what's the best place where people can reach you?
You can find me on LinkedIn, LinkedIn.com, Eugene Manley Jr. You can find the nonprofit, LinkedIn.com/company, STEMMCHEQ. And you can use those same letters to find us on Facebook and Instagram. I do a lot of posting there. I do have Blue Sky. We don't have use it as much, but we do have those channels. But also we have the website, SCHEQ.org. We have information about the summit. And if you really want to find two great resources, are our blog, which has different materials and posts. And then we have in our resources page, we have information for patients. So we have some infographics that we've been creating that break down medical information and cancer information. So SCHEQ.org/blog will take you to the blog.
Yeah. Okay. I was giving the letters in the beginning, but it's Shack. I love
SCHEQ.
that. I know that was so cool. But Shack, I love that Shack. Okay. So we all know the best place to reach you. I kind of want to ask you a two-part question. Because I know we're really coming up close at time and but I wanted to ask you a two-part question. Um, if you can leave a message to people in the medical profession, that's part one. I would like you to leave a message on how they could do whatever message you like. And then for our listeners, they're on the standpoint as a patient. Um,
Yeah. Okay. So if you're a medical professional, really try to take the blinders off for where you go into patient engagement, and be willing to listen to what your patient is saying. They have many different lived experiences and what they're going through, and they may not necessarily tell you everything that's going on, but you can't assume they're all like the majority population. So be willing to listen and hear what they say, and don't dismiss them. Like, it's really, really important, because when you start doing that, they just will they will engage less and then not care. And there's enough stuff on that in the literature. As for patients, you know, you this is my key thing. If you're going into an appointment, don't necessarily let the doctor dictate that appointment. Go in and sort of research, and I hate to say this, Dr. Google, but go in, like, if you have something that's wrong, try to go and read up on it, and go in with like 3 to 5 questions that you have for that doctor about, what these are my symptoms, or I was on this, or I heard that this might work. They don't necessarily like to hear all therapies, but you are within your right to ask questions about your care. Specifically, if you know it's a condition that you have, then you should be your own expert on your condition. Don't necessarily rely on a doctor when you know how your body works. It's like, I'm a chronic asthmatic and allergies, and the first allergist I had in New York just was not listening to me. And so I switched to an allergist. Like, I've had my allergies and I know how my stuff manifests. And so my new allergist, like, okay, I'm like, if I call and say I have a chest infection, I promise you I have a chest infection, because I've been dealing with this so many years, but that takes a lot of trust. But I can tell the difference between a cold, flu, and chest infection. So he knows I don't call because I hate going on the steroids. But that takes a doctor that really, really listens and knows how you understand your body. But you are within your right to ask questions, but go in and prepare with questions and ask about results that are in your chart and ask if you should be addressing anything. And then also even think about if they did a metabolic panel, then ask what those tests say and indicate. Don't just read the my chart. Well, clear, like, no, what do these numbers mean? You're within your right to ask these things. That was probably way too many nuggets, but
No, that's that. This is what we need because it's just not a cookie cutter thing. I mean, there are layers to this, and I mean, literally, you could be like I could have you on this podcast 4, 6, 7 times, and we'd be covering so many other things. I mean, because it's not as easy to navigate.
oh, it is not. It is not at all. And the terminology is off. And one system uses one thing. And then if you have doctors in two different healthcare systems, then that's a whole challenge because typically they keep your data siloed within that one healthcare system. So that's a big issue in care delivery as well.
Yes, that is so true. So yeah, I mean. I hope you know this, and I tell this to all my guests that are here. Now, you are part of La Familia, and you're part of the Life and In Between Familia, and we would love to have you again. If ever you'd love to come back again, we love, and I'm sure our listeners would love to hear more from you because you're not only giving knowledge, you're giving them knowledge, you're breaking it down, but you're empowering people to take action. And that is the most key important thing that we want people to realize that they need to empower themselves and they have total control of this. And thank you for sharing all that. Um, are there any last final words that you would like to share?
I just want to say thank you for having me on. I hope this is informative for your audience and they have some takeaways that they can do either how they engage care or how they think about how they're being treated in healthcare and that they're inspired and like you said empowered. My big thing is about empowering people to either do what they want or empowering them to advocate for what they need and not just accepting the status quo. And I'm just say it was just a pleasure to be on here, and I'll be happy to come back on anytime you want.
I would love to have you back, and we're gonna have well, yes, I definitely would love to have you back. And I want to thank you again. It's been such an honor, such a pleasure to have you here, sharing your knowledge, sharing your experiences, being transparent. And and this is what I say to all my guests, because the people that I select to be on this podcast are special and they make a difference to the world. And so thank you so much for making a difference.
Thank
Um,
you so much.
Thank you. And for our listeners out there, please reach out to Dr. Eugene Manley and really look into what he has to say. Look at all the information, really empower yourself. For those that have not subscribed to Life and In Between, you can subscribe, share, like this episode if you enjoyed it. If you want Dr. Eugene Manley to come back next week, you tell me, and I will have him on next week. But yes, you can find us on Spotify, on all the social media platforms. We're out there, iHeartRadio, YouTube, and all that. And thank you again for being a part of our community.
Thank you so much. It was a
Thank
pleasure.
Peace.